Hello, everyone. Welcome to another session of IACH for Nurses. Welcome all the participants. Thank you so much for joining us today. Today we have another wonderful speaker, Ms. Julie Klinger from Texas Children's Hospital. She's a physician assistant and instructor at Baylor College of Medicine and an expert in managing pediatric patients who are undergoing high-dose chemotherapy, such as stem cell transplant, CAR T-cell therapy, and also gene therapies. She has a host of experience in managing these patients at her clinic. She also had a lot of experience in developing the educational material for her program. She's also Associate Fellowship Director for the Physician Assistant Hematology Fellowship Program at her site. And I also want to congratulate Julie for being appointed as President-elect for Society of Physician Assistant in Pediatrics, which is a very reputed professional organization in the United States. So congratulations, Julie, and thank you so much for sharing your expertise with our audience members today. Today, we will be covering a very important topic of oncofertility, focusing on fertility preservation techniques in young patients who are undergoing high-dose chemotherapy and radiotherapy. So please note down any questions. Our chat option is open throughout the talk. And after the next 35 to 40 minutes of talk, we will cover a live question and answer to go over all the questions from the audience member. Thank you so much. Julie, take it away.
Thank you so much for that introduction. And thank you guys for joining me today to discuss what I think is a really important topic. And although I'm going to be kind of taking a pediatric perspective on this, I think it still can be applicable to a lot of y'all that are treating adult patients as well. So our objectives today is we are going to essentially define what oncofertility is, and then we're going to talk about both pre and post-pubertal fertility preservation options for both males and females. So what is oncofertility? It's essentially just how do we maintain fertility for these patients who are undergoing cancer therapy. And why is it important? I think we all kind of know this is important, but let's kind of dive into why this is so important for our patients. Specifically in pediatrics, we know that there's been so much advancement in cancer therapies over the years that now greater than 80% of patients, pediatric patients who are being diagnosed with cancer are surviving, which is amazing. But with that comes long-term survivors who have complications and long-term side effects of their chemotherapy and surgery and radiation. And we know that one of those impacts is on fertility. And there's been a lot of studies done on this, and it really shows that survivors of cancer express regret that their fertility was impacted, and they weren't necessarily counseled on this. So they didn't really know that this was going to be impacted. They didn't know that, in the future, they might not be able to have children of their own. And so, I think as providers, we never want any of our patients to express, regret about the decisions that they made or the things that they've gone through. And the studies have shown that these kind of uncertainties about their patients, their fertility has negative impacts on their quality of life. So again, as providers, we don't want our patients to have poor quality of life. Just getting them through cancer is not our goal. We want to get them through cancer and to have a great life after cancer. So I think, the big piece of this, what's really important about this is how do we counsel patients on this? How do we talk to patients about their fertility and the potential impacts of their fertility, their treatment on their fertility? And so I really think it's important that all patients who are undergoing cancer therapy should receive counseling on the potential impact of therapy on their fertility. So every patient, kind of regardless of kind of how high risk it is for them or kind of their chance of fertility, really should receive counseling. And ideally, we want that counseling to occur prior to initiation of therapy, because that's when we're going to be able to make the most impact in terms of fertility preservation options. I don't think that if a patient isn't counseled at initiation of therapy that we should just throw the towel in and not do it. But this is going to be the best time. But it's certainly something that can come up at other times and should be readdressed if there's a change in therapy, a change in plans. If they're referred for stem cell transplant, that's a time where it could be addressed. And then even in our long-term survivors as well. So a good way to kind of approach this conversation with families and their children is kind of stratifying their risk of fertility or infertility in the future, and this can kind of help guide the conversation on kind of what is the risk and how do we address it for this patient. So for risk of infertility, the biggest thing that's going to be contributing to this is alkylating agents. And so I put a list on here of the most common alkylating agents that we use. And then the second table that I have on here is the cyclophosphamide equivalent dose calculator, which is like really cumbersome and looks like a lot. But they do have calculators online that you can kind of plug some of this information in as well. But basically, taking the plan of the patient's chemotherapy and calculating what their cyclophosphamide equivalent dose is can help you determine their risk of infertility. So I have two slides here. One is specifically for females, and based on that first row is based on the cyclophosphamide equivalent dose, kind of tells you whether they're at minimally increased risk, significantly increased risk, or high level of increased risk. And you can see on here that being prepubertal, you actually need more cyclophosphamide equivalent to have an impact. So that is one kind of positive that we have, right? So our patients who are prepubertal and maybe don't have as many fertility preservation options are at a kind of lower risk of infertility based on their exposures. And then we can see patients who are undergoing transplant. Again, those are the patients that I'm primarily going to be seeing. Essentially, all of them are going to be at a high level of increased risk of infertility. And so I think this is a really important discussion. And then we know that not only chemotherapy affects our fertility, but so does radiation. And for our patients who are receiving radiation to the ovaries, it's the dose is not as a lower dose can cause an impact than compared to those that are affecting the hypothalamus. And again, we know that fertility is not just about the eggs or the sperm, it's also about the hormones that we need. And that's why radiation to the hypothalamus can cause issues with reproduction in the future. All right. So risk stratification for males, you can actually see on here that it actually takes a lower dose of cyclophosphamide equivalents or alkylating agents to affect male fertility. So our testes are a little bit more sensitive to the effects of alkylating agents, and even more so, you can see radiation exposure. It really doesn't take much radiation exposure to put a patient at some amount of increased risk for infertility. And then again, our transplant patients are going to be at a high level of increased risk. So I think, any patient that's undergoing cancer therapy, we need to counsel our patients on the risk of infertility, and we can use this risk stratification system to determine kind of the general amount of risk that they pose. And so that can be helpful in the discussion of what to do next. So once we've had this conversation with a patient about, that there is a risk of infertility after their cancer therapy, it's time to kind of talk about what are some options that we can pursue to help with this. So when we talk about females, first we kind of want to determine, is the female prepubertal or postpubertal, because this determines what our options are. So for prepubertal patients, the mainstay, or really the only option that we have, is something called ovarian tissue cryopreservation, which I'll get into further on in this talk. And then for post-pubertal females, the kind of gold standard or ideal best case scenario is oocyte banking. But sometimes there are barriers to this where we cannot pursue oocyte banking. And then we can also offer these patients ovarian tissue cryopreservation. So ovarian tissue cryopreservation can be used both in prepubertal and post-pubertal females. And then I wanted to put this on here, but this is definitely like a controversial area. But we do offer our patients kind of hormonal suppression as a means of possibly preventing infertility. It's certainly not something that we offer in place of oocyte banking, since oocyte banking is definitely going to be that kind of gold standard best case scenario, but it is something that we will offer if that's not an option for them. And then for males, again, same thing. We're going to try and determine, are they prepubertal or postpubertal? And then what does that mean for their fertility preservation? Our prepubertal patients, our only really option is testicular tissue cryopreservation. And then for postpubertal, again, our gold standard kind of best case scenario is that they're able to bank sperm, but some aren't able to. Either they're too sick or they are too young to really understand how or what to do. If they are able to bank sperm, then obviously we're going to pursue sperm banking if they're interested in doing that. But if they're unable, there are still some options that we can use, both surgical and non-surgical options. And I'll go into those just a little bit. So that's kind of an overview of the preservation options that we have. And now I'm going to kind of dive in a little bit more into females first, and then I will switch over to discuss males. Before we dive in, I do want to do just kind of like a brief overview of the reproductive system. I think we all know this, we've all learned this back in school, but it's always good to kind of talk about it a little bit. When we think about fertility, I think obviously we think about the oocytes, we think about the eggs, but there's a little bit more that goes into puberty and the reproductive system. And so, once a patient goes through puberty, that's when we start having the hormone production that leads to oocyte maturation. And so we have our hypothalamus, which releases gonadotropin releasing hormone, or GnRH, and this stimulates the pituitary to secrete luteinizing hormone, or LH, and follicle stimulating hormone, or FSH. And both of these hormones work on the ovary. And the ovary is going to be producing our estrogen and our progesterone, which is going to help with follicle, those kind of premature eggs, maturing into oocytes and ovulation. And so you can imagine that chemotherapy or radiation that affects any one of these components can lead to infertility, whether it's the hormonal system or the eggs directly. So back to this diagram that I showed you guys of kind of the different options. We're going to dive into kind of this post-pubertal area first, because I think it's kind of just the more straightforward aspect. So I think the most people here on this call are probably pretty familiar with egg banking or oocyte banking. This is kind of, what we think about with patients who are undergoing IVF, even those, outside of cancer therapy, or are adults who are undergoing cancer therapy. Oocyte banking is going to be kind of the best case scenario for these patients desiring fertility preservation. And so what this looks like is it's hormone injections that they receive for about 10 days. And the goal of these injections is to stimulate multiple eggs to mature. And then those eggs can be collected through a procedure called oocyte retrieval. In kind of an ideal scenario, a patient who's undergoing IVF, we time those hormonal injections to coincide kind of with their menstrual cycle. But we know in a patient who's just been diagnosed with cancer, they could be anywhere in their menstrual cycle. And so the reproductive endocrinologists have really done a good job of trying to figure out the best way to do this a little bit quicker for our patients. And so they are able to to start kind of any point within a cycle. They don't need to wait for the beginning of a cycle. So that does help a little bit time-wise. But we are still looking at about 10 days for the injections, then the procedure, and then a recovery time of maybe 2 or 3 days after the procedure. The procedure itself is minimally invasive. I put a picture on here so you could kind of see what it looks like, but essentially it's typically done transvaginally, where they're able to retrieve those oocytes. So again, we're trying our best to kind of shorten that lead time, but we're still looking at about 2 weeks that they're going to have to defer therapy before pursuing this. And for some cancers, that's fine, and we have that time. But then for some cancers, we don't. And that's where we might consider some of these other means, such as ovarian tissue cryopreservation, which I'll talk about in the prepubertal section, but can actually be done for postpubertal patients as well. Another option that applies to some patients is ovarian transposition. This really only applies to patients who are going to be getting radiation that involves the pelvis. But basically what this is they surgically move the ovaries and the fallopian tubes out of the field of radiation. And so by doing so, they aren't exposed to the radiation and they're able to kind of preserve their function. This sounds really great and sounds like it would be a really good option, but it's not really that straightforward. So if you think about it, if we're moving the ovaries because the pelvis is going to be receiving radiation, that means that the cervix and the uterus are still going to be receiving radiation. And it actually would be unsafe for these patients to carry a pregnancy in the future. So patients who undergo ovarian transposition surgery are not able to bear their own children. They're not able to carry a pregnancy. So future pregnancies would be done through in vitro fertilization and surrogacy. So they would have to have a surrogate to carry the child if they wanted to have their own biological children. An added benefit to this is that by preserving the ovarian function, you're also preserving that kind of hormone function that the ovaries have, which is also very important. As we know that patients who undergo cancer therapy can have early menopause. And we certainly know that those symptoms aren't super enjoyable. That being said, they don't necessarily recommend ovarian transposition just for the means of kind of ovarian preservation. It's really done for patients who are interested in fertility and then kind of has that added. Okay, I want to talk about gonadotropin releasing hormone agonists a little bit. I think this is a controversial area. I think there's not enough research on this to know if it's truly helpful. There's been some research that shows that it can help preserve fertility, or patients who receive this had increased chance of having children. But then there's been some research that hasn't shown that. So it's controversial, but I think it is something that we can offer patients. An example of this medication would be Leuprolide or Lupron, which is what we typically use. The way that this works, it's kind of thought that by blocking the hormone production and preventing the eggs from maturing, we're kind of protecting the fertility in some way. There are, unfortunately, side effects associated with this. Since we're blocking hormone production, we are essentially putting them into kind of this temporary menopausal state. So they can have side effects of kind of what you see with menopause. So we could see hot flashes, we could see mood disturbances, we can see difficulty sleeping or vaginal dryness. This can be mitigated with what we call add-back therapy, which is typically norethindrone and is usually pretty well tolerated in our patients. I think for this specifically, it's not necessarily something that we offer as like, hey, let's give this medication to preserve fertility. We give it more as a means of menstrual suppression. So we know that These patients who are undergoing chemotherapy are going to drop their counts and they're going to have thrombocytopenia. And if they were to be menstruating when they have thrombocytopenia, this could lead to pretty heavy menstrual bleeding. And so we will offer this to patients as a way to suppress their menses and prevent, kind of a bleeding and kind of having the added potential benefit of helping protect against infertility. Okay, so that's post-pubertal. Let's go and dive into our pre-pubertal females. And as I mentioned before, really the only option we have is ovarian tissue cryopreservation. So ovarian tissue cryopreservation, I like this picture because I feel like it's kind of just a very basic overview of what it looks like, but essentially part or all of an ovary is surgically removed, and then the tissue is kind of processed and frozen. And then when a patient is ready to have a child, they are able to thaw that tissue, transplant it back into the patient, and then they're able to ideally or hopefully conceive naturally. Recovery time from this procedure is a couple days, and so it doesn't require any like lead time. It doesn't require stimulation medication like oocyte banking does. So it can be done essentially when a patient is diagnosed, and they can start chemo pretty shortly after. So that's definitely a positive, a perk of this this method. It's not the most efficacious in that only about a third of the time does it result in a successful pregnancy. And of that, about half of those end up needing to do IVF. So it's definitely, there's still a lot of room for improvement in this area, and there's definitely research being done. Worldwide, there's been about 130 live births using frozen ovarian tissue. But from what I could find, only one of those was collected pre-pubertally. So, it's certainly possible, but it's not, there isn't as much research in this area. It's not considered experimental since there has been live births. But like I said, there's kind of limited data, especially in patients who are pre-pubertal. And there is the added benefit, like we talked about when we were talking about ovarian transposition, where by giving them back their ovaries, we do kind of have that the ovarian function that allows for hormone production. But once it's transplanted back in, the ovary really only tends to live for a short period of time. I saw anywhere between like 1 to 10 years, with the average being about 5. So once a patient is ready to pursue, once they want to have children, they kind of need to time this appropriately. One caveat of ovarian tissue cryopreservation is that if the patient has a hematologic malignancy like leukemia, or a tumor that tends to have ovarian involvement, there's this risk that, by preserving the ovary and then implanting it back into the patient, that we could be reimplanting or reintroducing malignant cells. And after everything that our patients have gone through, we certainly don't want to be reintroducing their cancer by any means. And so for these patients, we would still offer them ovarian tissue cryopreservation, but the plan long-term would not be to transplant them back into the patient. And there's still kind of research being done on how do we use that ovarian tissue in the future. The research is kind of being done on how do we mature these eggs outside of the body, so in vitro rather than in vivo. And because this is still kind of, it's not experimental, but there's still a lot of research being done on it. We really only offer ovarian tissue cryopreservation to pre-pubertal females who have kind of that highest level of increased risk. Okay, so that's all of our preservation options for females. I'm going to go ahead and dive into males. And again, we'll just do a quick overview of the male reproductive system. In terms of kind of our hormones, it's kind of similar. Our hypothalamus releases the gonadotropin releasing hormone, stimulates the pituitary to release follicle stimulating hormone and luteinizing hormone. The FSH acts on our Sertoli cells, which are pretty important to spermatogenesis. It's kind of, they are right there with our spermagonial stem cells. And then our Leydig cells are crucial in testosterone production, which we know helps the maturation of sperm. This is a picture kind of zoomed in on the testes, specifically in the seminiferous tubules, which is where we find the sperm. And we can see the Sertoli cells in there are very kind of critical to help with the maturation process of the sperm. So in our prepubertal patients, we're kind of looking at more of those stem cells that we're seeing in there rather than the mature cells. Okay, so back to our lovely diagram, our overview. I'm going to start with our postpubertal patients again. I think it's just a little bit more straightforward, and then we'll talk about prepubertal. So sperm banking, that is best case scenario, gold standard, what we want to do and what we want to offer all patients who are able to do it. So any patient who's postpubertal and any patient who's even like kind of going through puberty, kind of Tanner stage 3 or 4, should be offered sperm banking. And that's because it's non-invasive, it's quick, and it can be done without any delay in therapy or any recovery time or anything like that. We do recommend 2 to 5 days of abstinence from ejaculation, but this isn't necessary. So if that's not the case, they can still collect and we can still get adequate sperm. But if we do have the time, this is what we recommend. And if they really want multiple kids, or they're worried that they're not going to get enough sperm, or the sperm that they do collect is kind of low in volume, they can bank multiple times, and this can be done within a couple of days. So there's really a lot of opportunity for these patients, these male patients of pubertal age. I also want to mention that this can be done not only like in a facility, but it can be done or like a clinic. It can also be done in the hospital. So for our patients who are newly diagnosed, presented to the ER with symptoms concerning for cancer, we can have them sperm bank that day or the next day in the hospital. And so that's an option. And we can also do home sperm banking. I believe it's a little bit more costly to kind of get the kit for it and everything. And the timing is a little bit, you have to get it to the facility quickly. But for especially like our younger kids that might feel a little out of place at a fertility clinic, at 14 years old, it's a good option to offer for these patients. If patients are unable to ejaculate or do not have any sperm present in their semen, there's still ways of obtaining sperm so that we can cryopreserve it and use it in the future. There are ways to surgically extract sperm. There's lots of different methods. I thought about diving into the different ones, and then I decided this wasn't a urology talk, so I won't do all that. But if this is something that a patient needs, then we'll refer them to urology and they can determine the best course. But essentially, they somehow, whether it's through an incision or a needle biopsy, go into those seminiferous tubules of the testes and they obtain sperm that way. The amount of sperm that is collected through surgical sperm extraction is typically much lower than you would get in a sperm banking sample, and sometimes can be more immature. And so they aren't able to be used in kind of the standard IVF method. They typically are going to have intracytoplasmic sperm injection, or ICSI. I put a little picture of this because I kind of had to actually look into what this was. So I kind of just wanted to show you guys. On the right side of the screen, you can see kind of conventional IVF, where the oocyte is in the middle and the sperm is kind of just put in there, and whichever sperm finds the oocyte is the one that fertilizes. Whereas ICSI, they have to actually inject the sperm straight into the oocyte. So they have to help with kind of that motility portion of the fertilization. So it's a kind of subtype of IVF that they would have to use for these patients. And then if a patient isn't able to collect that way, there are non-surgical methods as well. I think there's multiple options, but really the main thing that I have heard of is electroejaculation, which is kind of a procedure where they sedate the patient and they use electrical current to stimulate ejaculation, and then they're able to collect the sperm sample that way. So if a patient is unable to sperm bank, we will refer them to urology so that they can pursue some of these other methods. I had a patient, he was maybe, I think, 14 years old, beta thalassemia, who was referred for transplant. And we were planning for his transplant. And this was several years ago, before we had like a really good established Oncofertility program. And I think somewhere along the way, the conversation of fertility just didn't happen. He wasn't really counseled on it very well. And it was either the day of admission or the day before admission. And I had a conversation with this patient, and fertility came up, and it was either the first time this family had heard it, or it was the first time it registered with the family that he was most likely going to be infertile after his transplant. And so we were like, okay, that's fine. He's old enough. He can sperm bank. We'll send him off. We'll send him to the sperm banking clinic. It's down the street. I'll call them right now. They can go right now. We'll get it taken care of. We can still proceed with the transplant. And this patient went, and I won't get into the details because truly I don't know them, but I don't think he knew how to, or knew what to do, or was comfortable with doing this. And so, him and his dad come back. It's like 5 p.m. on the day that he's supposed to be admitted, and they're both in tears because he wasn't able to sperm bank, and they really want him to be able to have children in the future if they want to. And, this patient had beta thalassemia. This was not an urgent transplant. We said, okay, we're going to delay this transplant. That's something we can totally do. We're going to delay transplant, and we're going to see how we can get you your fertility preserved, because this is really important to you in the future. And so we referred this patient to urology. He was able to see urology, and they were able to do a surgical sperm extraction. So that's just kind of an example of a situation where this might kind of come into play. And, thankfully we had time on our side this time, and that might not always be the case. But even if we didn't have time, usually urology is able to accommodate pretty quickly. And so I think it still could have been an option, but we didn't have to kind of rush in this scenario. Okay. So that is our post-pubertal patients. Let's talk about pre-pubertal. Really, the only option here is our testicular tissue cryopreservation. And this is still experimental. So this is not a kind of approved method of fertility preservation, but it is something that we offer our patients. It's basically a procedure where a small amount of tissue is removed from the testy and then frozen. And the goal is that we're going to be getting those stem cells that are going to, in the future, create sperm. There's a lot of research ongoing on kind of how this would be used in the future. I think there's kind of one avenue where you would kind of re-implant those that tissue, and hopefully they would be able to then collect for IVF and ICSI, or how do we actually take out those stem cells and then give those back to the patient, and then are they able to then conceive naturally? So a lot of research ongoing here, and there's been no live human births to date, But I think the thought process is kind of these patients are, they're prepubertal, so they're less than 12 years old. They're probably not going to be looking to have children for another 10 or 20 years. And so the hope is that research will kind of catch up in that time and be able to figure out how we would use this in the future. So we actually don't have a IRB at our hospital, but we have one at a hospital that's, I think, about like 4 hours away from us. And so we have a close relationship with them. And anytime we have a patient that expresses interest in this, they'll do a telemed visit with the family to determine if they want to pursue. And then if they do, they will go up to that site to get it done. I did kind of skipped over the part, but there has been a live birth in non-human primates. So, experimentally, we have seen that this can work. We just haven't yet proved it in humans. And one thing that, we worry about, as I mentioned, with our ovarian tissue cryopreservation is kind of that risk of re-implanting cancerous cells. So again, another area of research is how do we mature the sperm outside of the body in vitro so that they can be used in the future. Okay, so that's all of the kind of methods and the way that we can do it. And I think it all sounds really good on paper, right? But I think we all know that in reality, it's just not always that straightforward. I think when a patient is first diagnosed with cancer, there is so much going on. They're getting all of this information, and there's so many different pieces to the puzzle, and fertility is just kind of one piece of that. And it's a very distant piece, especially for some of my patients who are very young. And so there can be a lot of barriers to fertility preservation. So let's talk about them a little bit. I think a big one is time. I think time comes up a lot, and I think we've talked about that a lot already in this presentation. But do we have the time for these fertility preservation options? And sometimes the answer is no. And that's why we kind of have these other methods, which maybe aren't as ideal, but are still an option. So like for females, if they don't have time for oocyte banking, can we offer them ovarian tissue cryopreservation? And if not, can we at least do loop ride and potentially have some benefit from that? Finances are a really big one. These fertility preservation options are typically not covered by insurance. And it's a lot for the families to pay for, especially in like these younger kids who are going to have these products frozen for decades. And so that's definitely something to think about. And I think, it's really important to engage social work and engage, all these different, there's so many organizations out there that want to help patients with cancer. And so there's definitely avenues for it, but your team has to be kind of aware of those to be able to provide those resources to families. The severity of the illness can be a really big barrier. And unfortunately, I don't think I really have an option to overcome that. If a patient is so sick when they present with their cancer that, they can't do fertility preservation, then you have to focus on saving the patient first, right? But that doesn't mean that you can't have a discussion. I think that's what's so crucial. It's just because we can't pursue cryopreservation doesn't mean that we can't talk to the family about it, because just knowing and understanding is so important. Another big barrier is provider knowledge, and hopefully that's something I'm addressing in this talk is, patient providers not feeling comfortable with discussing these things or not really knowing the different options to offer to families. And so just being aware of what you have as options, and then also kind of being aware of kind of relationships within the hospital. So if you're going to be offering this to patients, then you need to know a gynecologist and a reproductive endocrinologist that can see them today to talk about it. And so kind of building those relationships and having a plan is really crucial. I think we, as pediatric providers, and I'm sure there's some people on here who aren't providers, but you can kind of understand that the dynamic between a parent and the child is can sometimes be a barrier. Maybe the parent really wants it and the child doesn't, or they don't care for it, or they're too young to understand. So that can be a really tough kind of gray zone to approach. So that's certainly a barrier to fertility preservation and discussions. And then, of course, as always, our different cultural and religious beliefs can impact this discussion. So I did want to put just kind of 1 or 2 slides on here specifically about the financial considerations, because I think this is a really big thing. Sperm banking, it's not cheap. Typically upfront, the cost for kind of the semen analysis and cryopreservation can be anywhere between like $250 to $600. And then there's also an annual storage fee of about $100 or more, depending on where you're storing it. And then for females, oocyte banking is even more expensive, like in the 10,000 plus range. And so I think this is really tough. I've had patients before say to me, we really want to do this, but I don't know how we're going to do it financially. And that's really hard to hear. So one way that we can mitigate this, and we do this with our patients all the time, is coordinating any sort of a procedure with something that's already medically necessary. So again, I work in transplant. All of my patients have a central line. And so if a patient is interested in pursuing ovarian or testicular tissue cryopreservation, we will work with surgery and with gynecology or urology to schedule those procedures together. And that means that the insurance will cover the kind of OR fees and the anesthesia fees that are required for the central line placement. And then we just have to worry about the actual kind of procedure itself and the freezing fees. So this is one way to mitigate costs, and it also mitigates risk too, right? Because we're decreasing the number of procedures they're having, decreasing the number of anesthesia they're having. And then, obviously, I think involving social work is really important. Our social workers have like a very organized way to kind of approach these patients and identify what financial needs that they have. And then depending on their financial needs, they have different resources that they can offer. I did just want to put 1 slide on here about just some different companies that we have, or organizations that we have referred patients to about financial support. So many of these will help with like the either the cost of the oocyte banking or sperm banking, or the yearly fees for cryopreservation. And then the one on the bottom, the Heartbeat program, that one is specifically for the medications that you need for oocyte banking, which can be very expensive. So I didn't put like links on here or anything, because I don't think you can click on them, but if you just Google those, you should be able to find those. And then the last thing I wanted to touch on was just briefly talk about long-term survivors. Just because a patient wasn't counseled on fertility, or even if they were counseled, it doesn't mean that you can't discuss it in the future. And so for our long-term survivors, they're typically seen annually, and we do a lot of screening labs. And once they've hit puberty, we do recommend screening with those hormonal labs, the LH, FSH, estradiol, and testosterone. And if we're seeing abnormalities, we are going to refer them to the specialists. Even if we're not seeing abnormalities, but they have further questions about the impact of their treatment on their fertility, or if fertility preservation options are still an option for them, it's always a great opportunity to refer them. And so I just think, we don't only need to talk about fertility preservation, before treatment, but I think it's important to talk about it after treatment in our long-term survivors, and just kind of keep that discussion open, because they may have the question and just not feel comfortable asking it or know how to ask it. Okay. So just some kind of final conclusions about this talk. I think fertility is it's a complication that we can see in essentially all cancer therapies, and it's a really important one to patients. Whether or not they can be parents in the future might be really, really important to them. And we really should be counseling all of our patients on this risk. And then when we're talking about fertility preservation, I think a multidisciplinary approach is so important. Our hematology oncology team is obviously at the forefront of this, but really the people who are going to be doing the preservation options are going to be our urologists, our gynecologists, our reproductive endocrinologists, and then also, our social work with that kind of financial aspect is so important. And so I think having those relationships kind of set up before you kind of run into the scenario where a patient is needing this is really important. I think that's all I had for you guys today. Here's a list of my references, and I think we'll have some time for questions.
Okay, well, Julie, so first of all, thank you so much for such a comprehensive overview of this very difficult topic. And it's always helpful to kind of walk us through your clinic workflow. So I'm going to start with one question which I had listening to your talk is, can you give me an idea about the structure of Oncofertility program in your hospital?
Yeah, absolutely.
Just you see patient and the decision to oocyte preservation, warm banking, and then
So I lost you a little bit there, but I'll address the first question that you asked, which was kind of what our Oncofertility program looks like. And so I think first off, it's our whole oncology, hematology oncology department is part of Oncofertility, right? And so we have kind of some documents that help us kind of guide these conversations with patients. And so any provider who's seeing a patient should be able to kind of address this. And so it starts with a kind of frontline provider, the provider that's taking care of the patient and kind of bringing this up and what their risk of fertility is and what the options are. And then if the patient is interested in pursuing fertility preservation or wants to have further discussions, we have a specific Oncofertility team that's composed of, I believe, one MD and 3 nurse practitioners. And they can meet with the patients either urgently in the hospital, or they can set up an outpatient appointment either in person or telemed to discuss these things. And then they are the ones that kind of have very close relationships with our urologists, gynecologists, reproductive endocrinologists, our outside facility that does the testicular tissue cryopreservation. And so they are the ones that are kind of facilitating all that, but it's something that starts at every provider. So I heard your question about kind of what our Oncofertility program looks like, but I think you had a second part to that question that you kind of broke up on.
I just wanted to understand the time frame. So it looks like you guys are able to evaluate this patient in the hospital too, which is quite an unique resources to have. Certainly that's not available at my hospital. So that creates a lot of barriers. Do you guys have any protocol in place for like disposition of fluids? Like this sperms and oocytes are frozen, like a patient or a parent, or what to do with them?
Yeah, so again, you're breaking up a little bit, so I'm not 100% sure I heard the question right, but I think you were asking about what happens kind of after they're frozen, and that's really dependent on which kind of banking facility that they go with. So it's really more them that set the kind of protocol for that rather than us.
Hey, I'm not. My my connection is quite poor here. So if I lose connection, can you ask the questions if you can hear me?
I'm looking
Sure,
in
if
the
you can hear us.
chat.
Julie, hear
Yeah.
me?
I'm looking in the chat, so let me go through them. So it says, if a minor is below the age of legal consent, I advise you need to consider whether to restrict disposition in the future to avoid potential conflict of interest between patients and their adult parents. Yeah, I mean, I think there's definitely a legal component to it.
My colleague is at what patients you actually select for GnRH analog use? I know people use it quite liberally on our adult side, but do you have any protocol of list of criteria where you use this agent versus not use at all in your practice?
Sorry, you broke up but it was the gonadotropin releasing hormone agonist. Yeah. So honestly, we will offer it to any patient who is having menstrual cycles and is at risk for thrombocytopenia. So any of those patients, but we do refer to gynecology if that's something that we're interested in, and they are the ones that manage that.
I was in one situation where a patient has an aggressive disease who needed treatment right away. But the parent was interested in pursuing the fertility preservation, hence wanted to delay this potentially curative chemotherapy. And so how do you navigate this conflict? Because I really struggle in that situation.
Yeah, I think that's a really tough question that I don't have a perfect answer to. I think it's just a matter of kind of discussing it and the risk benefit of both avenues. And I think you just have to talk through the patient and the parent about that and kind of what that means for them and what delaying chemotherapy would look like.
Let me see if there is any additional questions here. Put on the question in the chat box. Oh yeah, I'm not put it. Julie,
so I see a question in the chat. It says, sorry for confusion. My question was whether your informed consent for underage minors allows them to donate their gametes in the future or requires discarding them if they don't use. That's a good question. I would think that that's something that would have to be they would have to be consented to once they became of age. So I think it's something that has to be kind of brought back up.
Yeah, at least on the stem cell side in adult, we always consent them for up to 5 years. I'm talking about the stems, frozen stems.
Yeah.
And then we send them notification before kind of say, okay, it's 5 years. Do you want to continue to store it or discard it? But yeah, okay. Let me see if there's, we have a few more. Okay, well, just a comment. Perfect, wonderful. Well, we'll wrap this up just for the audience member. This will be archived on IACH website and will be available for anybody's review later in the day. So thank you everyone for joining us this morning or tonight. And again, Julie, thank you so much for your expertise. And I hope with this information, I'll be able to convince my gynecologist to have this kind of inpatient service available for our patients, because we really hate to delay the treatment for our patients who are interested in this type of fertility preservation therapies. So thank you so much.
Thank you.